Now talking about the cholestasis, alkaline phosphatase is the main marker of the cholestasis. It's the normal values vary between among different laboratories. The half-life is of 7 days. Basically, it is produced from the hepatocytes. It is also present in the bone, in gut, kidneys, and placenta. Biliary obstruction raised levels due to the induction of the AST may not rise until 1 to 2 days later. Whenever there is obstruction, there is increased level of alkaline phosphatase seen. It is seen in elderly people as well as in children in pregnancies because of placenta and sometime after fatty meal. We are more concerned with the pathological causes, that is the intrahepatic cholestasis and extrahepatic cholestasis. The intrahepatic cholestasis is sometimes seen in cases of resolving acute hepatitis and because of the damage to the swollen biliary duct, while the extrahepatic cholestasis could be because of stone, stricture, malignancy. This is a graph which is showing age-related changes in the level of alkaline phosphatase, which elevated in adolescence and then comes to a plateau and then slightly increase in elderly. So pathological causes of intrahepatic obstruction, some drugs such as antitubercular drug, septicemia, are infiltrative liver diseases such as a patient can have hemochromatosis, a patient can have sarcoidosis, primary biliary cirrhosis, primary sclerosing cholangitis, and sometimes in cases of a malignancy when there is a paraneoplastic manifestation of raised alkaline phosphatase. The extrahepatic obstruction, gallstones, you know very well. Similarly, malignancies, and it could be something from outside such as pancreatic malignancies, lymphomas, and sometimes Meniere's syndrome when there are a lot of gallstones. Gamma GT is main utility is to differentiate alkaline phosphatase source because this is not found in the bone, it is not raised in malignancy, neither it is raised in childhood. So its sources are liver, kidneys, pancreas, intestine, prostate, spleen, heart, and brain, but mainly it is present in the liver, and if it is isolatedly elevated, it could be due to induction of the hepatic microsomal gamma GT. It could be because of the drugs such as warfarin, anticonvulsants, barbiturates. Uh, it is also isolatedly elevated in those people who take alcohol. If the level of gamma GT is elevated along with the alkaline phosphatase, this could be a marker of a metastatic liver disease as well. And if the patient has got other predisposing factor, the practicing clinician has to try to find out whether this patient has got any malignant disease or not. Coagulating factors are mainly synthesized in the liver except factor 8, and they are always in excess. The prothrombin time, you know that the factors are involved are factor 1, 2, 4, 6, 9, and 10, and the shortest is factor 7. So whenever there is an acute damage to the liver synthetic function, this prothrombin time is the basic marker for a clinician to interpret the liver function, synthetic functions. It is also used as a prognostic factor because in those patients who have got chronic diseases of the liver, we measure serial prothrombin time to see the prognosis of the disease. Similarly, albumin is also synthesized in the liver. It is 300 to 500 grams in body fluid. Around 15 grams of it is being synthesized daily, and its half-life is up to 21 days. So it may not be a good marker for an acute liver disease, but in cases of a chronic kidney disease, especially those patients who are suffering with the chronic kidney disease secondary to hepatitis or some metabolic diseases, this albumin level is a clear-cut marker of the synthetic function of the patient. Naturally, it is dependent upon the nutrition. If the patient is not taking proper nutrition, the albumin may be low in cases of malabsorption or malnutrition. Other factors such as catabolism, hormone, or stool or urine losses can also be an important factor while you are interpreting albumin, as in cases of nephrotic syndrome or in patients who have got protein losing enteropathies. So the albumin level may be low, and it may not be because of the liver disease. So hypoalbuminemia, decreased synthesis, because of poor malnutrition, chronic kidney disease, chronic inflammations, increased losses such as in cases of nephrotic syndrome, protein losing enteropathy, increased volume such as in patients who have got decompensated disease of liver, having lot of ascites, and catabolic states, steroids. So we can measure globulin, we can measure the cholesterols and triglycerides, which will help us in making a decision whether the liver synthetic functions are compromised or not. This is an important slide showing the bilirubin metabolism. It is a degradation from the RBC. The heme is produced. It's an unconjugated. It's unsoluble, so it is bound to the to albumin. Then it is brought to the liver hepatocytes where a conjugation has been done with the glucuronide, and it becomes a conjugated bilirubin, which can be easily excreted through the urine and stool. So unconjugated bilirubin, also known as indirect bilirubin, it's less than 0.1 milligram per deciliter. It is bound to albumin in plasma. It cannot be filtered because it is not water soluble. The conjugated bilirubin is the one which we call it direct bilirubin. Its normal value is around up to 1 milligram. It's water soluble, so it's excreted in bowel, it's excreted in urine, and it is most of it is being absorbed in the glomeruli, but some of it is being excreted in the urine. Isolated unconjugated hyperbilirubinemia. If there is an unconjugated bilirubinemia, as an adult physician, for me it may be because of some hemolysis, or it could be because of some hematological disease leading to ineffective erythropoiesis. Sometimes it could be because of the drugs such as rifampicin and ribavirin. Same, the ribavirin causes hemolytic anemia. And sometimes if a patient has got trauma and there's a big hematoma and it's been released, so the heme is being released to the circulation. Defect in hepatic uptake or conjugation, which is usually seen in adolescent. This is Gilbert syndrome and Krieger-Najjar syndrome type 1 and type 2. Conjugated hyperbilirubinemia is seen in those patients who have got damage to the liver cells. It could be damage to the hepatocyte. It could be damage to the biliary canal E. coli. Usually the patient, they passes dark color urine and clay color stool, and there could be malignancy which may be causing an obstruction leading to conjugated hyperbilirubinemia. Delta bilirubin. Conjugated bilirubin, when it is being present in the blood for a longer period of time, covalently bonds to albumin. It is an important fraction of total bilirubin in the patient with cholestasis and hepatobiliary disease, as the albumin has got a prolonged half-life, so it remains there for a longer period of time. In late recovery phases of damage to the hepatocyte by any infection such as hepatitis, most of the bilirubin may bound to the albumin, and then it remains there in the blood. It explains two enigmas in the patient with raised conjugated bilirubin. Conjugated bilirubin declines slowly in patients who are recovering from the acute hepatitis, and no bilirubinemia during recovery phase, and this is because it is an albumin bound bilirubin and which cannot be filtered by the glomeruli. So in these type of patient, when we do liver function test, the transaminases, they are showing a better result as they are regressing, while the bilirubin level are not regressing, are rather increasing, and the patient get worried why this is happening. So this is because this bilirubin is bound to albumin, and as it is bound to albumin, it has got a longer half-life and it will stay there for a longer period of time. So the principle of liver function test, we talk about it, the pattern of the abnormal liver function test. We have seen hepatocellular injuries, the most important, AST, ALT ratio, level of elevation, rate of decline, biosynthetic function, prothrombin time, albumin, and then now we are going to talk about the score for prognosis. This is a child croquet score which was first presented in 1964. The parameters which were taken into consideration at that time were ascites, level of bilirubin, albumin, encephalopathy, and nutritional status. It was classified into a type class A, B, and C. If patient has got ascites, easily controllable ascites, and a resistant ascites, bilirubin less than 2, bilirubin between 2 to 3 or greater than 3, albumin greater than 3.5, less than 3.3 to 3.5, and less than 3. Encephalopathy mild, advanced, and nutritional status is excellent, good, or poor. The MELD score was basically devised in those patients who were undergoing uh, liver transplant, but it has been also used by the clinician to find out the extent of damage in their patients who have got chronic kidney disease. So the MELD calculator is available online and it is 3.8 uh, serum bilirubin milligram per deciliter plus 11.2 into INR plus 9.6 into serum creatinine plus 6.4, and ln is the neutral logarithm which is inbuilt in this score, and this score is easily available for calculation, and for patient who are not on who are on dialysis, then the creatinine is rounded off to 4, and any value less than 1 is also rounded off to 1. If MELD score is less than 9, the patient has got good prognosis. If patient has got MELD score of greater than 40, they are more prone to the mortality. And this MELD score is used to prioritize those patients who need liver transplant. Hyponatremia is a marker of severity of cirrhosis. So in some cases, it has been also incorporated in the MELD, and the hyponatremia is predictive of wait list mortality, more independent of the MELD score. So it shows a poorer outcome in those patients who are going to have a liver transplant. Hepatopulmonary syndrome, a very dreadful complication of a chronic liver disease, and usually these patients are having uh, a very bad prognosis. Primary auxiliary, usually necessitating combined liver and kidney transplant, cystic fibrosis, and hilar cholangiocarcinoma, provided that the transplant center listing the patient as a protocol to detail the workup and the management of the cholangiocarcinoma patient for the liver transplant. So the conclusion is that liver function tests are numerous and somewhat confusing. But one thing which is there, that whenever we do a liver function test, they give us an insight. If we have got an abnormal liver function test in our patients, what we can do, we can find out the cause. Say if the liver enzymes are elevated in a patient with mildly jaundice, and patient is having symptoms of fever as well as tenderness, it looks like to be an acute hepatitis. This may mimic with a patient who have got liver abscess, but certainly the blood CP in the patient who have got liver abscess may be elevated. Similarly, in those patients who have got chronic hepatitis, the liver enzyme tests are borderline elevated, and sometimes in these patients the synthetic function is preserved, so may be having a normal prothrombin time. But the ALT and AST, they will be elevated, and sometime we will be able to find that these patients have got other clinical signs of chronic liver disease. So these liver function test interpretation is always dependent upon the clinical acumen and other associated findings. Similarly, if you have done these liver function tests and you have to find the etiology of the damage, then you have to do the investigations such as for viral etiology, we do hepatitis B surface antigen and anti-hepatitis C antibodies. In those patients in which we suspect that there is some metabolic derangement, we go for serum copper and ceruloplasmin level and the urinary copper levels to find out whether these patients have got Wilson disease or not. In patients in hemochromatosis, we also go for serum ferritin level to see whether this is the one which is causing damage to the liver. Similarly, alpha-1 antitrypsin deficiency can give rise to a chronic liver disease, and its level can be measured in specialized laboratories. Autoimmune hepatitis should always be kept in mind whenever you are interpreting your patient who have got abnormal enzymes, because this disease is present in our community and sometimes it is underdiagnosed. It can be diagnosed when we do go for an anti-nuclear antibody or anti-liver kidney microsomal antibodies, or we can go for the extended autoimmune liver profile, which is nowadays easily available in most of the labs of the city, which can tell us about this. Similarly, antimitochondrial antibodies and the investigation from primary biliary cirrhosis are easily available, and we can go for these investigations in our patient to find out what is the cause of these abnormal liver function tests. So liver function tests, they are the most important investigation in those patients who have got liver disease, and they have to be investigated till the diagnosis of the cause of the liver damage has been established, and then it will be decided how to manage these patients. The clinical risk score do not offer any diagnostic yield but indicators of a prognosis of liver disease. CTP score is widely used. We are using it, and we are also using other scores such as FIB-4 as well, so that we should be able to decide about the prognosis of our patient who are having chronic liver disease.